see that. So before we start, I would just like to acknowledge the traditional owners of the land on which we're meeting today. The North Western Melbourne Primary Health Network would like to acknowledge traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wathaurong people. And we pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. A little bit of housekeeping. So we've got the webinar set up tonight, so all attendees are muted. We have a Q&A session, Q&A box, so please pop your questions in there and we can answer them throughout, or we do have a panel discussion with the multidisciplinary panel that we have this evening for additional questions. This session is being recorded, but questions will be anonymous to protect your privacy. So if you need CPD points, Sadia, who's working behind the scenes, might contact you and just ask you if your name doesn't correctly update on the Zoom, you'll need to change your name. That will make it easier to make sure we can allocate points as needed. There's some information there on how to change your name. Please sing out in the chat box if you need any help from Sadia, but click on participants at the top of the Zoom window and you can hover your mouse over the name in the participants list and actually rename yourself there. So really excited to have such a broad range of speakers tonight, and in preparation for this session around long COVID, certainly looking at the numbers that we're still getting, you know, COVID is certainly unfortunately far from over, and having a look at the sort of the numbers that we've seen in Victoria. We've had over 2 million COVID positive cases in the Northwestern Melbourne Primary Health Network region. We've had over 649,000, which equates to about 31% of all cases in Victoria. So certainly a huge burden in our PHN. So this topic is really important. So we have joining us tonight Dr. Elizabeth Williams. Elizabeth's a fellow of the RACGP and has worked as a GP for over 25 years. Elizabeth's the lead clinician heading up the COVID safe group at a large private general practice in Melbourne's northern suburbs. So great that we could have a local GP part of this session. We also have Dr. Alistair Miller. You will have seen Dr. Miller's face on a number of our education sessions, a respiratory physician at the RMH and Peter MacCallum Cancer Centre, and has played a really big part in terms of the West Metro COVID positive pathways, as well as contributing to health pathways modules on acute and long COVID, and also sits on the primary chronic care panel of the National COVID-19 Clinical Evidence Task Force. And we're also joined by Dr. Tissa Wijeratne, and Professor Wijeratne is a senior neurologist at Western Health, where he's the director and chair of the Department of Neurology and Stroke Services at Western Health, really interested in promoting brain health and preventing neurological disorders globally. So really excited to have such a great panel with us tonight. Just a quick sort of run through the agenda. So Dr. Williams is going to kick us off with a bit of a GP assessment of a long COVID patient. Alistair is then going to talk us through the sort of pathophysiology, the respiratory conditions after COVID-19 and what to be aware of. And then we're going to have the perspective of the neurological impacts of long COVID by Tissa, so talking about sort of brain fog and headaches, etc., and then plenty of opportunity for questions to the panel of cases that you may have or general questions from the session. So thank you so much again for joining us on a very chilly night. I hope you're somewhere warm for this session, which will no doubt be really interesting. So I will stop sharing and hand over to our first speaker, Elizabeth, to kick us off.
Thanks, Bianca, and hello, everyone. As Bianca said, I'm a GP in Pascoe Vale, so really local for you. And over the last couple of years, I've headed up our COVID safe working group. Someone said to me recently, oh, I think how good it's going to look on your CV, you know, giving these talks and heading up your COVID safe group and setting up your vaccine clinics. And quite frankly, I would have rather not had the last 2 years and have an empty CV. But anyway, this is where we find ourselves. I thought we'd start with a case study of quite a typical long COVID case study from this year. And then we'll talk about this in a bit more detail. So I've called her Matilda. Matilda's a 59-year-old woman. She's got a past history, some relevant past history. She's got an inflammatory history with her inflammatory arthritis and a low positive ANA. She's got hypertension, hyperlipidemia. She's obese, and she's got hypothyroidism, also thought to be autoimmune. And she got COVID in January 2022. So presumed Omicron, as that was the start of the peak of our Omicron wave. She was moderately unwell, although not admitted to hospital, fever, chills, cough, lethargy. She at that point had had 2 vaccines and was considered fully vaccinated, and so wasn't eligible for any of the treatments. I think at that point probably only sotrovimab was available, but she wasn't eligible. And she was managed through the COVID care pathways with regular telehealth consults with myself and my colleagues at our practice, so regular GP contact. She was, as I said, moderately unwell. She had a fever for more than a week, and on the 8th day she was even more breathless and assessed in the emergency department for possible pneumonia, and commenced on both antibiotics and budesonide at that point. I think I must have been on leave, it was January, and on day 20 she was still coughing but improved, but she was reporting chest heaviness, quite a significant breathlessness on exertion. She was fatigued, her heart rate was really spiking whenever she moved around too much, and she was referred back to the emergency department initially and then had some outpatient workup with a cardiologist. And she had, very typically, a normal troponin, a normal CRP, normal D-dimer, normal ECG, normal CT pulmonary angiogram, normal echo, normal CTCA. Normal, but she was not back to normal by any stretch of imagination. In week 5, she's still very tired, quite breathless on exertion, and had this annoying, distressing tachycardia heart rate spike at quite random times. The cardiologist told her at that point she had long COVID. I will disagree with that diagnosis and explain why a bit later, but she certainly had signs of an inappropriate sinus tachycardia, which he was calling autonomic dysfunction, and marked fatigue. In the 3rd week, she started to return to some part-time work. In the 10th week, by the 10th week, she was working full-time from home. By the 12th week, she was working 1 day a week in the office, but still fatigued, still breathless on exertion, still intermittent heart rate spikes, and long COVID certainly is an appropriate diagnosis for her. And we're now 5 months down the track. We're still managing a return to work plan. We're still doing fatigue management. We're working, she's seeing her exercise physiologist regularly, and she is very typical of what we're seeing in terms of long COVID. So let's think about what are the possible outcomes if you do get COVID infection. Of course, the vast majority of us will recover fully in the expected time frame. There might be symptoms, certainly with Omicron, there might be symptoms for 5 to 7 days, but by the end of the time someone's released from isolation, they're feeling quite well and they're recovering. That's the most likely outcome by far. Of course, you might die from your COVID infection. The risk of dying from COVID in Australia for those who are unvaccinated is about 3% for people aged over 70 and 0.02% for those aged under 30, and something in between for everyone else. And there is a small gender difference. So death is an unlikely outcome with COVID, particularly with Omicron in Australia currently. You might end up in hospital. Hospitalisation rates currently in Victoria are sitting around 4% of our known cases, although of course our known cases probably is not the true number. 4% are hospitalised, and of those people in hospital, only 1% of them are in ICU. So not 1% of everyone with COVID currently, 1% of the people in hospital currently end up in intensive care. And ICU admission in particular has its own set of sequelae, particularly prolonged ICU admissions, as we were seeing in 2020 and in 2021, where people were in hospital or in ICU for weeks and in hospital for months. That has its own set of, recovery sequelae, which we're not really going to talk about now, but we're familiar with managing patients who are very deconditioned from being in hospital for a long time. Their pre-existing conditions might get worse. Their asthma might be worse. Their heart failure might be worse. Their diabetes might be worse. So we might be having to manage this problem for people following their COVID. They might get one of the serious sequelae of COVID. For example, they might get a pneumonia. They might get myositis or pericarditis or a venothrombotic event or have a stroke. And we'll talk a little bit about how to tease them out. They may not fully recover, and this, of course, is the point of our talk. I'll be able to come back to that. They may have quite profound psychological impact from a number of things, from the trauma and uncertainty of their diagnosis, their isolation, their illness. They might have ongoing issues with the difficulties that their functional impairment might have, and we might be needing to manage a lot of psychosocial distress following a COVID diagnosis. And concerningly, there's more and more reports about the adverse health outcomes for people who have COVID, regardless of how severe the disease is and regardless of whether they've fully recovered or not. There was a large US study published last month or the month before, which showed that a history of COVID increased rates, and sometimes quite significantly increased rates of heart attacks, stroke, AF afterwards. And just in the last couple of weeks, another study has said that the rates of diabetes, newly diagnosed type 2 diabetes, are 28% higher in the 12 months after COVID than in people who haven't had COVID and are matched for other risk factors. So clearly there's emerging evidence that COVID infection itself is not a benign condition, and the ongoing health implications and the adverse health outcomes down the track, we're probably still understanding that. You're all probably feeling very depressed now. But let's think about these group of people who don't fully recover. And I think it's quite helpful to think about that in terms of time frame. So if we see someone with COVID, we've been talking to them on the phone, they're out of isolation, we might bring them into the clinic to review things in the second or third week, and they've got ongoing symptoms. The second and third week, it's quite common to have persisting symptoms, and we would just say to them, you still have COVID. It's not that you're necessarily infectious with your COVID, but you're still having the effects of COVID, and it might be that we need to provide some reassurance. We might need to do some workup for that. Then there's a group of people whose symptoms are still going on in the 4th, 5th, 6th week, up to the 12th week. And there's a bit of debate about terminology, but I sort of think that they're in this middle group. It's probably too soon to call them long COVID, and I'll come back to definitions again a bit in a minute, but there is certainly a group of people who have symptoms in their 4th, 5th, 6th week, having had COVID, and we can be quite optimistic that most of them will actually continue to improve. And the terminology that's trying to be used is the post-acute COVID symptoms for that. This is as per the NICE guidelines, and our health pathways are endorsing this sort of terminology. But then this is a group of people who've got signs and symptoms for more than 12 weeks. The symptoms may vary over time, they can fluctuate, they change over time, it can involve lots of body systems, as I'll talk about. And that is the group we are particularly thinking about tonight, the ones with a post-COVID syndrome, or what we are terming what we're calling long COVID. So what is long COVID? Actually, it's not complete agreements. The World Health Organization has said that it's a condition that occurs in people who've probably or definitely had COVID, lasting 3 months or occurring for 3 months from the onset of the COVID, and can't be explained by another diagnosis. Interestingly, the CDC in the States and the UK guidelines both talk about long COVID as being persisting symptoms for 4 weeks or more. So when you look at research around long COVID, you have to think about how are they calling it, and rates of long COVID and that sort of thing. You have to think about, well, what time frame are they using? Australia appears to be going with the 12-week definition for persisting symptoms for the long COVID. And how common is it? Well, again, that's a bit unclear. Initial reports in 2020 was that 30% of those who were hospitalised had symptoms 6 months after the hospitalisation. That was a study out of the UK in 2020. And 13% overall, including people who weren't hospitalised. That, of course, was pre-vaccination, and that was some of the earlier variants. New South Wales similarly was reporting that 20% of those infected in 2020 had symptoms at 3 months. A recent study published in The Lancet last week compared rates with Omicron and Delta, and they put the rates at about 5% for Omicron, for those infected with Omicron variants, and about 10% for those who were affected with some of the earlier variants, in particular Delta. But as I said, they are defining long COVID as more than symptoms for more than 4 weeks. So it's actually unclear whether the drop in that is due to the effects of vaccination, whether it's a variation because of different variants that perhaps are more likely or less likely to produce long COVID. We were thinking that vaccination might reduce rates of long COVID by probably 40 to 50%. And there is no formal tracking in Australia. So how common is it? Perhaps about 5% currently. And it's also unclear at this stage what effect early treatments will have on long COVID rates. So we don't know whether antiviral use will reduce rates of long COVID or not. What symptoms consist in long COVID? Well, what symptoms don't come up? This is a list of the commoner reported long COVID symptoms: fatigue, headache, neurocognitive effects, breathlessness, persisting anosmia, cough, and so on. You can see the full list there. And of that list, this group on the left are the most common reported symptoms. Although I've said symptoms can fluctuate over time, there are gender differences in terms of what people experience. And so this is not an exhaustive list by any means. So what are our assessment priorities as the GP? I think we've got 3 priorities that we need to be working through, and probably working through sequentially. First of all, we need to make sure we've given adequate consideration to the serious sequelae of COVID, and I'll talk about that a bit more in a minute. We need to think about long COVID as a diagnosis, keeping in mind the timeframes, and we need to provide education, support, and referral. And it's going to be the good old history, examination, investigation matrix, of course. We need to talk to patients. We need to talk to patients about their illness, the symptoms they experienced at the time, how severe they perceived it to be, when did it occur, how long did it last. I had a colleague tell me at lunchtime today that she had a patient who came in and said she wanted to talk about her long COVID, and when she started the history, when was your COVID? It was 2 weeks ago. Okay, it's not long COVID. We can be pretty sure about that. The World Health Organization definition, I don't know if you picked up, it said confirmed or presumed COVID. So in actual fact, a COVID diagnosis, a formal COVID positive test is not required to make a diagnosis of long COVID. We had plenty of people in January in particular who had COVID and were not able to get a confirmed test. You can take a collaborative history. You know, everyone else in the house was sick. Somewhat, you know, at least some others around them had COVID. But a positive test is actually not required to make a diagnosis of long COVID. You can make a presumptive diagnosis of COVID and then think about long COVID too. You certainly want to ask them what symptoms they are experiencing now, referencing back to that long list. We're going to think about red flags, and I'll show you the list of that. But you also need to talk to them about how are they feeling? How are they feeling about their illness experience? What debriefing do they need to do to you? And listen to their concerns. Red flags. We've got to be thinking, as we do with our acute COVID calls and management, what are the things I've got to pay attention to now? And this, of course, is not rocket science. Breathlessness, hemoptysis, chest pain, syncope, arrhythmias, palpitations, marked confusion or neurological signs. They're the things we've got to pay urgent attention to. And it's worth asking, particularly, do you have any of these things? We're going to examine them, of course, including oxygen saturations if we can, a targeted examination relevant to their symptoms. And we're going to undertake some investigations perhaps, and Alistair's going to talk some more about how to tease out who actually needs investigating or who doesn't. Some of the things that you might think about, though, particularly in those with any persisting cough, would be to do a chest x-ray. You might think about some cardiac investigations or referral, and you might think about some basic bloods. But often, if you're seeing them 3 or 4 weeks after their COVID, there might not be much to do from an investigation front. But what are we wanting to make sure we're going to diagnose? We're going to make sure that we don't miss a new coronary disease, new heart failure. We certainly want to think about the possibility of pulmonary embolism and the ongoing symptoms of that. Could they have a pneumonia or a respiratory complication from their COVID? Do they have one of these rarer conditions to think about? And clearly someone who's a bit more unwell post-COVID may need quite a workup to exclude some of these. I want to talk a little bit about this pediatric multisystem inflammatory syndrome temporarily associated with COVID. Quite a mouthful. In my mind, I think of Kawasaki's and I do the correlation. This is a post-COVID, a rare post-COVID inflammatory condition that children get, where they look unwell, they've got signs of shock, they've got abdominal pain, fever, and a rash. And the COVID might have been 6 or more weeks ago and could have been quite mild. And as I said, I'm sort of thinking the Kawasaki kid and thinking, could this be the MISC thing? Sepsis is a differential, and these children probably need working up in hospital. And interestingly, when I was looking at lists of serious sequelae, I was unaware, but there is actually adults can get a version of this too post-COVID. So that's some of the more serious stuff we need to be thinking about as we're talking to someone about their post-COVID symptoms. And what do? Well, we assess urgently if we think that's required, emergency department, prompt cardiac referral, prompt respiratory referral if required. We give them some education. This could be long COVID. There is no diagnostic test. It's supportive care. Sometimes these people are not yet fully vaccinated or boosted, and it's important to discuss vaccination and to reassure that there is no evidence that vaccination worsens long COVID. And in fact, vaccination is beneficial in terms of preventing a second COVID infection down the track. So obviously we've got the time frame not to vaccinate after COVID, but once that 12 weeks is up, then they should be boosted if they're due. And we may well choose to refer. We could refer to post-COVID clinics, and almost all of the major hospitals now have a multidisciplinary post-COVID clinic. We might refer specifically to the cardiologist or the neurologist or the respiratory physician, depending on their symptoms. I would highly recommend involving OT and in particular exercise physiologists whose strength is exercise prescription at all levels and all capabilities, and can make a very big difference to people's optimism about their recovery. And we might need to provide quite significant mental health support for these people who turn out to be having quite a chronic illness experience. They need regular review and they need our support. Post-COVID services in Melbourne, as I said, almost all the hospitals, in fact, I would say all the hospitals now have a post-COVID clinic that we can refer to, including the Children's Hospital. The psychologists have got a lot to offer in this field, I think, with chronic disease management. Generally, some of the things that they might be working on would be some cognitive challenging and reframing around the illness experience. They might be able to provide help with sleep management or behavioural activation if they're finding it hard to get things done. It might be that mindfulness and acceptance is important in terms of modifying responses to a situation that they can't otherwise control. Pain management strategies and fatigue management strategies. Now, fatigue management is at the heart of managing long COVID. And I found an extremely useful resource which has really changed my approach to this. Instead of just saying phrases like, you need to conserve your energy, fatigue management and being explicit about that can be incredibly helpful. And this approach, the 3 Ps, is one that we can easily remember and discuss and provide resourcing around. And the 3 Ps of fatigue management, and this is not, of course, specific to long COVID, but applies to many chronic fatiguing conditions. The 3 Ps are pacing, planning, and prioritising. So pacing means you save your energy by breaking up your tasks into littler tasks. Planning means, okay, I need to shower. I'm going to make sure everything's at hand and I don't have to go backwards and forwards to get things. It might also be, I've got to do 3 things today, but I'm not going to do all of them 1, 2, 3. I'm going to do 1 and then have a break and do the second and have a break and so on. And I'm going to prioritise. I've got 5 things I could do, but only 2 of them are important. And so I'm only going to do them and I'm going to save my energy. And patients, this is really a concrete way of approaching fatigue management that I have found very helpful to talk about in more detail and get them to write down the 3 Ps, and they often really benefit from this approach. There are some other useful resources. The RACGP has got a patient booklet and also a GP resource on managing post-COVID symptoms, and it's got some useful strategies, including fatigue management discussion. And the Australasian College of Sports and Exercise Physicians has quite a useful flow chart in returning to physical activity post-COVID. The Primary Health Network will share these resources with you. I think tomorrow I've provided them there. Health pathways. If you don't know health pathways, you need to get on it because it's just an excellent resource generally, and its COVID resources has just saved my bacon so many times over the last 2 years. And they do have 2 particular pathways around post-COVID and post-COVID referrals. It talks about definitions and the red flags and how to investigate and all that sort of thing. A very useful thing. In fact, their whole COVID related pathways are excellent. And in particular, at the moment, I am constantly referring to their COVID positive management pathways and the early treatment within that and the eligibility and so on, which is really quite hard to get our head around. So health pathways, if you're not registered, you can register yourself. I think we need to acknowledge the uncertainty. This is a new phenomenon and there's a lot that we don't know. Most patients improve over time, but some of them don't. And it's important to acknowledge uncertainty when we're dealing with them, as well as engendering optimism about recovery. And I think that is a bit tricky to do. But that's the way I approach long COVID, and really interested to hear from Alistair from a sort of more of a hospital respiratory physician approach to some of those teasing out that we need to do in the early assessment.
Excellent. Thank you so much, Elizabeth, for that really great practical presentation. What I might do, there's no questions in the Q&A box that I can see, so I will hand over to Alistair Miller, and there may well be some in our Q&A session. So thank you so much for that. Over to you, Alistair.
All right. Can you hear me there, Bianca? Sorry.
Yes, yep, we can hear you and see your slides. Yep, sorry.
Excellent news.
I think I was looking a bit concerned.
Thank you very much, Bianca, and thank you for the opportunity to talk tonight, and thanks, Elizabeth, for a really great start to the session. As Bianca mentioned, I am a member of one of the task force committees and a member of a medical advisory board for anaesthesia, make one of the oral antivirals. So look, in the next short while, talk a bit about what we know about the mechanisms of disease. It could be a very, very short talk, realistically, given how little we really know about it. I'll talk a bit about some respiratory post-COVID symptoms and diseases and how we might approach the investigation and management of those. But before I do that, I thought I'd just reiterate, and I guess very much along the lines of what Elizabeth was saying, that really, while we talk about COVID and post-COVID, we're probably not talking about one condition. And I think this is something that a number of people have talked about, and something certainly we see in our clinic. There's those people who have had very severe disease, who have been in ICU, that's been intubated for long periods of time. They're often have multiple comorbidities, and their disease leaves them with structural lung disease and complications, as Elizabeth talked about, of critical illness. These people tend to have a sort of slow but progressive recovery, and they may be left with structural lung disease or neurological symptoms, but it tends to have a fairly linear improvement. In contrast, however, is the other group of people who often have very mild disease. They're often younger, they often don't have significant comorbidities, and their symptoms are often quite disproportionate to their acute illness. And indeed, people often describe their symptoms being much worse many months after their acute illness as opposed to the time infectious. Their course is often not linear. It often waxes and wanes, and it's often made worse by new infections or other insults. And it's really this group that I guess, as Elizabeth said, that we're really most interested in, because it's somewhat new, not entirely new, but somewhat new to most of us. And I think, we also need to distinguish between COVID exacerbating pre-existing disease. We may well find new conditions in the context of investigating the symptoms that people have that may or may not be related to their symptoms and may or may not be related to COVID at all. And we may find new conditions that are directly related to the COVID. Most of the people that we see in clinic are actually people who have significant symptoms for whom we can't find an identifiable cause, and we don't have anything to measure, at least in an objective sense. The scientist in us likes to measure something, and we really can't for many of these people. And one of the questions, I guess, is why do people get long COVID? And the short answer is we simply don't know. There are lots of different theories, and certainly one of them revolves around dysregulated inflammation.
Alistair, can I just
Yes.
interrupt for 1 second? Sorry. We seem to be having some crackling with your audio. So I don't know if it's a connection problem with your headphones. You're kind of coming in and out. I don't know if others are picking that up, but if not.
Is that better?
Yes, that's much better. Thank you.
Okay. All right. Sorry about that. Oh, no, it's still crackling, isn't it? So give me a moment. No, it does not want to let me change anything. All right, I'll push on, and hopefully it's not too bad. We know that that the acute infection is characterised by this really severe, profound inflammatory response, and many of the complications we see, and indeed many of the subsequent effects of COVID relate to this inflammation. In this context, and in the context, I guess, of the acute respiratory distress syndrome that we see and the critical illness, there's quite substantial cellular damage associated with both direct viral invasion and the inflammatory response. There's also quite marked changes in the homeostatic mechanisms within the lung itself, and a really high cytokine load, which favours fibrosis rather than resolution of that inflammation. What's less clear is why this causes ongoing symptoms in some people and not others, and indeed in mild disease where there isn't this profound inflammation, why do these people get ongoing symptoms? Interestingly, there doesn't seem to be a link between inflammatory markers and fatigue, although there is some evidence of an inflammatory impact on both skeletal and cardiac muscle, which of course may be exacerbated by the inactivity that's seen in acute infections. And so there's certainly some thought that this may contribute. There is quite a lot of work, some really lovely work done by a group based at the Kirby in Sydney, who studied a group of largely non-hospitalised patients who had ongoing symptoms beyond 12 weeks as part of their ADAPT protocol. And they showed that in people who had had COVID as compared to healthy controls and those who had had other viral illnesses, there were elevations of inflammatory cytokines, particularly type 1 and type 3 interferons. And while those went down in people who didn't have persisting symptoms, they remained elevated in those with ongoing symptoms. And there were some other changes in immune function noted, particularly some persistent activation of both T and B cells. There is also a suggestion that the virus is able to mimic the immune response and the formation of autoantibodies and deposition of these in a number of organs has been suggested as a cause of ongoing symptoms. So another question that's commonly asked is, is there virus left over? Could it be avoiding being mopped up by the immune system, and are there viral reservoirs? It's certainly a long-standing putative mechanism for a number of diseases. And certainly in COVID, that there's some evidence of viral persistence in a number of organs, including neural tissue, but without the evidence of inflammation. Earlier this year, there was a study published showing that in people who had virus detectable in their feces in week 1, a proportion of those out to 4 months, and indeed out to 8 months, still had RNA detectable. But of course, it's only RNA. They were not trying to grow the virus. We don't know what that really means in terms of treatment opportunities. But certainly, the study suggested that it was associated with ongoing symptoms, both gastrointestinal and other, although the small numbers make it very difficult to be definitive about. As Elizabeth mentioned, venous thromboembolic disease is a big problem in COVID. We know that there's really high rates of both micro and macro thrombosis in the acute setting, and this can affect a number of organs. We know that there is this sort of thromboinflammatory pathway that's activated in times of severe inflammation, and it's not unique to COVID. We know that rates of heart attack and stroke are higher after, in times of flu pandemic as well. And there are certainly some publications suggesting this idea of microclots, and that's certainly made it into the lay literature, and it's a common question that we're asked, what the significance of microclots are and whether we can treat people for that. If we look at it from a symptomatic point of view, tachycardia, labile blood pressure, muscular fatigue and shortness of breath are all very common symptoms. And they're all symptoms of autonomic dysregulation. We know that this is exacerbated by both bed rest and hypovolemia, which is pretty common in people with severe acute viral illnesses. And there is some suggestion, although not proven, that there are viral or immune-mediated changes in the autonomic nervous system rather that contribute to this. And finally, although you won't find discussion of this in patient forums, I don't think we can discount psychological factors in the as a contributor to long COVID. But teasing it out and separating it from physical symptoms is not really possible and perhaps not really necessary, given that we don't have specific treatments for long COVID, and taking a symptom-based approach is really all we have at this stage. And so treating physical symptoms and psychological symptoms in concert is really our best approach. So I think we know, as Elizabeth mentioned, that there's really a huge number of symptoms that have been described in people with long COVID. This graphic is from a systematic review published last year, looking at all the literature on long COVID, and really the definition of long COVID was pretty generous. You can see that they've ranked the symptoms that people describe according to the frequency, and fatigue is by far the commonest. Respiratory related symptoms are really common, and certain breathlessness or abnormalities of breathing occurs in 1 in 4 of 1 in 5 people. And if we stretch the respiratory definition a little further, again, there's quite a number of people who present with sleep disorders, and I'll talk briefly about this shortly. So after COVID, again, I'll separate it into those who have had severe or critical disease and those who have had mild disease. And certainly it's very common to see a restrictive ventilatory defect and reductions in the gas transfer after people who have had severe disease and diffuse pulmonary infiltrates. Persistence of those radiological abnormalities is very common, and we're now looking, following people now for a couple of years, and people have ongoing changes on their CTs. We know that PE is relatively common in the acute setting, although not perhaps as severe as we might see in other diseases. There's a number of people, and I guess you saw this with the volume of people coming through the hospital system with the large waves we've seen with ongoing oxygen requirements, and this generally settles, but we still see people with persisting requirements. And new fibrotic disease and new bronchiectasis, again, is very common in people who have had severe lung diseases. In contrast, I guess, that in people with mild disease, we don't see these structural abnormalities. And in fact, the vast majority of people have normal lung function. If people have underlying airways disease, they often will have exacerbations and often recurrent exacerbations after even mild COVID. Breathlessness without a clear cause is incredibly common, something that we see very frequently in our clinic, as is sleep disturbance. And perhaps up to a third of the people we see through our clinic describe some sleep disturbance. But really, the thing that goes across both of them is venous thromboembolic disease, and I'll spend some time on that in a moment in terms of how we might tease that out. So we know that some degree of exertional breathlessness or exertional intolerance is really common. Most people will recover inside 4 weeks, and the proportion who won't, really does vary over time according to who you ask and how you ask it. But somewhere between 10 and 40% will have ongoing symptoms up to 3 months. In the first instance, simple functional tests can be really useful, and they're useful for a number of reasons. They do help to rule out severe disease, but they can also provide some reassurance in a in a 1 minute sit to stand test, people will often become quite breathless, that their heart rates might rise, but with the use of an oximeter, you can show that even in that context, even associated with that severe breathlessness, oxygen levels remain within the normal range. Plain chest X-rays is really simple. The risks are incredibly low. And while the National Institute of Clinical Excellence recommends doing it by 12 weeks, I think it's probably reasonable to do it at about the 6-week mark if people have ongoing symptoms. Further sort of standard respiratory function testing, spirometry and gas transfer can be useful to exclude significant coexistent disease or exacerbations of underlying disease. And certainly further, more advanced testing, including cardiopulmonary exercise testing, again, can help to reassure us that proceeding with exercise therapy is not a dangerous enterprise. And then really further investigations have to be guided by these findings. Are we looking at a more infective or inflammatory picture? Are we concerned about pulmonary vascular disease or indeed cardiac disease? And is there something else? Could this be a malignancy? And certainly we've seen a number of people who have presented with malignancy in that period post-COVID, and both solid organ disease and hematological malignancies. And particularly in those people who have very long-standing symptoms, we don't know when it's presented, but certainly if people have symptoms for 6 months, it's very quite possible that they've developed an immune problem in that. So in terms of management for this, there's nothing special about management of underlying conditions in this context. There's nothing really that we know of that's contraindicated in that. TAP surgery is not recommended in the immediate time post-COVID. We know that inhaled corticosteroids are effective if they're started early in the course of acute infection, but their role is very much less clear in the longer term in those without airways disease. However, the risk is very low, and if people find benefit from that, the risk of harm is incredibly low from it. And so really we're left with, as Elizabeth mentioned, this idea of multidisciplinary rehab. And like Elizabeth, we lean very heavily on exercise physiology and occupational therapy and physiotherapy in terms of pacing strategies and prioritisation. The occupational therapists are also very, very helpful in terms of planning return to work and having an exercise program that slows people down more often than not. It's useful in trying to enable them to get back to the exercise they want to. In terms of sleep disturbance, it's really incredibly common. In my reading, this term coronasomnia has come up both in the lay press and indeed in scientific literature. And it's estimated that, certainly in our clinic, about 1/3 of people report some degree of insomnia. And this is certainly reflected in the literature. But it's not just insomnia. You see other changes, and this may be related to hospitalisation and critical illness. Lockdown really changed the way that people live their lives. Certainly lots of people who haven't been or certainly weren't for a long time back at work, and so there was significant blurring between home and work life. Not to mention high rates of screen time, doom scrolling close to bedtime is not great for sleep. We also know that there was a significant number of people who gained a lot of weight during COVID, and this certainly contributes to the development of sleep disordered breathing. Many people had new or recurrent post-traumatic type symptoms, and again, managing those in this context has been challenging. So in terms of insomnia, and really for many of these conditions, maintenance of good sleep hygiene is really important. We spend a lot of our time talking to people about managing their caffeine intake, managing their screen time, and indeed managing the anxiety that's associated with this whole period. Certainly management of coincident disorders is really crucial. Lots of people have pain as part of their post-COVID syndrome, whether that's chest or joint pain, and managing this is certainly necessary to optimise this. Certainly, for some people, the use of melatonin or short-term other pharmacotherapy, the Z drugs, can be useful in terms of short-term management. This is obviously a long-term strategy. And I think there is a role for referral into sleep services or to hospital-based post-COVID services for people who don't have resolution with these sort of conservative measures. People who have really profound hypersomnia may well need investigation of that in the sleep centre. So that brings me to post-COVID sort of venous thromboembolic disease. It really saw incredibly high rates of subsegmental PEs in critical illness literature. Yeah, it's somewhere up around sort of 30 to 40%. Interestingly, it wasn't, or hasn't been as significantly associated with changes in outcomes in people with COVID. In the post-COVID space, there are certainly a number of case series, genuinely small, describing PEs after initial recovery from mild COVID, and it's probably in the 2 to 3% range, and probably not dissimilar to post-COVID bleeding. In terms of trying to work out when it might be PE, generally speaking, and this is fairly consistently reported, it tends to be a biphasic illness. So people have had some recovery, are feeling better after their initial illness, and then have a new onset. And it's often associated with low-grade fever. It may be associated with new chest pain, breathlessness or cough, and hemoptysis is also quite common. Hemoptysis is not uncommon in the acute phase of the illness, but it does tend to settle down fairly quickly, fairly early on in the illness. And so new hemoptysis should certainly concern us for the development of PE or indeed other intrathoracic problems. So how might we approach this? I think it's important to use some sort of risk assessment tool, and I favour the years algorithm. I'll show you that in a moment. While there isn't strong evidence that validating these in a post-COVID space, they're certainly well validated across a number of populations, including pregnancy. And so I think it's worthwhile doing that. I think if the clinical suspicion is relatively high, then performing a D-dimer is entirely reasonable. And it can then help to guide next steps. This is a years algorithm, and it looks at 3 cardinal symptoms, really: clinical signs of DVT, the presence of hemoptysis, and whether it's the most likely diagnosis. It then divides the management from there according to whether any of these are present and what the D-dimer level is. There has also been work looking at whether changing this according to age makes any difference, and to this point it doesn't. So if they have a positive D-dimer, then CTPA is really the best investigation at this point, albeit it's somewhat difficult at the moment given given the contrast shortages. But not only does it give a good visibility of clots, it also gives us a good look at the pulmonary parenchyma to exclude other conditions. So finally, I just wanted to talk about vaccination and non-COVID. I guess it's something that Elizabeth touched on as well. And look, there's been a number of studies, albeit uncontrolled studies and small, suggesting that vaccines are not only safe, but may reduce symptoms in people with long COVID. There has been, again, a couple of studies that have been published looking at whether vaccination reduces the chance of ongoing symptoms, and there's certainly a suggestion that it does. But as has been alluded to, that this is in the context of less severe disease, and perhaps that may also contribute. So I won't talk too much on this because Elizabeth has already touched on it. I think the interesting thing, I guess, is that the POTS-like syndromes or other static syndromes do seem to be fairly common, and getting people to a cardiology service with experience in this is useful in terms of managing those symptoms. The multi-system inflammatory syndrome, interestingly, in adults, has a different time frame in terms of its definition. It's a much more acute sort of 4 days rather than 4 weeks, which is odd to call them the same thing. But certainly has been reported. So look, I think that obviously biased, but that the Clinical Evidence Task Force has an amazing service in terms of examining the evidence and synthesizing that, and it's a common sort of constant bit of work being done by the engine room of that service, and they're constantly looking for evidence because we simply just don't have any good evidence aside from rehab space. And the NICE guideline is a very good guideline, and what's sort of 6 months old or so at this point, it still has a good way of approaching management. Thank you.
Thanks so much, Alistair. We do have one question that I might throw to you. What might be the role of prophylactic aspirin in post-COVID setting given VTE risks?
Yeah, look, it's a really good question, and I think this idea of extended prophylaxis, whether it's with aspirin or the oral anticoagulants or indeed Clexane, has been talked about it, and I don't think we have any evidence that is a useful thing. As I mentioned, there is a rate of post-COVID bleeding as well, and it's probably not dissimilar to the rate of post-COVID PE or VTE, and so I don't think the evidence would support it at this point, or in the context that the evidence is not very good.
Great. Okay, thank you. That's all the questions for the moment. So thank you so much for that, Alistair. Sorry I interrupted about the sound quality. I don't know if it was a microphone problem. No, we could hear you. It was just a little bit, it got a bit better towards the end. So I'm now just going to hand over to our third presenter, Tissa. Oops. Over to you.
Good evening, everyone. Can you all hear me okay?
You're a little bit faint.
Can you hear me now better?
Yes, I think that's better. Thank you so much.
Just let me adjust my voice a little bit. Is that better?
Yes, I think that's great. If people are having trouble, just sing out in the chat, but that sounds good. Thanks, Tissa.
Thank you very much. Thank you very much for inviting me to be in this session, and also for organizing this as it is such an important event. And thank you all for spending your Wednesday evening listening to these talks, which are probably not a great deal of fun. Let me remind you all that how miraculous it is to be born as human to begin with, to set the scene. If you look at the mathematical possibility of one of your dad's sperm and one of your mom's the ovum to make you out of millions of cells that they had, the possibility of you being here today had been calculated to be 1 in 400 trillion. So even if you had a crap day at work today, if you feel miserable like me, as I am pretty unwell at the moment, not with COVID-19 so far, for this episode, that is, the currently tests have been negative. The very fact that we are here today is a miracle. It's mathematically 1 in 400 trillion opportunity. So just be happy. Despite I feel like a sick dog, I'm delighted to be here, honestly. I'm going to share my thoughts on COVID-19 and brain observations and suggestions. Before I get into slides, I would mention one more thing also. If I change this to a white screen, which I'm not going to do, and if I draw on my screen a mouse neuron on one side and human neuron on one side, if I ask you to show me which one belongs to the mouse and which one belongs to the human, I can guarantee that none of you would get it right knowingly. You might get it 50% chance because of the 1 in 2 probability, but you would not be able to know unless you are a postdoc molecular biologist who studied neurons in those two animals. Then how come we are much better than mouse? It is the large number of connections that we make since we came out of our mom's tummies throughout our life that make us who we are today. The two brilliant talks that you heard thus far, the fact that the Bianca and Sadia and other team members were able to organize this fabulous session, they're all part of those connections. So what we are doing today is making more connections. So that's a good thing for you also. And that's the second reason that why you should be thrilled and delighted and happy. And that's the same internally, the psychologically, not physically, me also. So the disclosure that I wanted to make is COVID-19 and brain involvement continue to fascinate many crazy folks like me, and probably like you also. Our group had successfully completed probably the world's first PhD in this topic, but this is still an evolving story. You heard this from previous speakers also. So all our comments are only valid for what we know today. So probably half of what I'm going to say to you is a truckload of bullshit. But the problem is even I do not know which half that is until further few years move ahead. That's how medicine is advancing. So I do not want you to make any decisions on your patients based solely on what I say today. I am another humble human soul with a bunch of neurons trying to fire. You should make an informed decision on ever-expanding knowledge with a critical appraisal that you continue to learn on a day-to-day basis. That would help your brain also. So a couple of frequently asked questions by some of my patients when they realize that I'm a reasonably friendly guy. From your perspective as a neurologist, how has COVID-19 affected Australians living with headache and other medical brain disorders? Is it okay for me to have a vaccine? That's a very common question in the past and even now. Is headache a common side effect of the vaccinations? Some would swear that they got headaches from vaccines. some would come and tell me that I should support their notion or the fight that they have with their GP. This is like just cold or flu, or is it something else? Some people. And obviously my other non-neurological disorder patients would tell me whether they can take medications or not. Some ask whether it could cause migraine, multiple sclerosis, a new daily persistent headache. Can there other brain disorders such as epilepsy, multiple sclerosis, Parkinson's disease? Those things can be treated while they had COVID-19. Some clever folks would ask, what's the link between COVID-19 and brain disorders? Long COVID is a very common question. Almost every clinic that I do, there would be 1 or 2 patients pose the question. I have written on post-COVID-19 neurological syndrome a lot. So they ask, is it a different disorder? Is that the same? And then they ask who would get that. The folks would ask, what's the role of inflammation? These are all questions that I copied from my documentation. Ongoing management, what they need to do with their routine habits, treatment as a result of COVID-19, whether they have long COVID or not. What advice would I give to people with brain disorder that they see me regularly in light of these multiple waves of COVID-19? So as of yesterday, these are the numbers of COVID-19 infections. As you and me both know, including Australia, these numbers are gross underrepresentation. I say this, my original home country, Sri Lanka, which is officially bankrupt as of now, they don't have any money to do COVID-19 testing, but COVID-19 is happening and deaths are occurring and long COVID is happening. But when you don't have money to pay for your basic meals, when you don't have fuel, when you don't have electricity, when you don't have a proper meal to eat for most days, your health services are not going to be particularly interested in COVID-19. There are about 40 countries like that globally as we speak. That's a global statistics while Ukraine and Russia is having a war. So you could imagine that the complacency that we see in our own home here, the numbers that I've depicted are probably 3-4 times less than what really is happening. This is a big deal. This is why we do need to talk about it and continue to do our bit to maintain humanity as best as we can without any borders. COVID-19 and brain involvement. At the very early on, when we got hold of our hand into the COVID-19 patients who ended up in neurology unit, we realized that this is going to cause havoc in our specialty, just as it caused in other entities. We generated plethora of papers. I believe we published something like 32 papers during the first 2 waves. So that's how we bust stress. When we were having sleepless nights, we put together data and converted them to manuscripts. So we did realize that the involvement of brain was almost a mandatory thing for COVID-19. This particular picture is from one of our publications of one of our first patients who had stroke-like symptoms. My team thought that I was going crazy when I was plotting the behavior of individual neutrophil, lymphocyte, and platelet count on a spreadsheet. This particular patient was with us for 4.5 months. Those of you who work in public hospital setting do know that when a particular patient is spending more than required length of stay, which is a KPI for you by your managers, you have regular meetings. Why your patient is still here beyond 1 week. Well, you could see why. You could see the peaks. Each of these peaks were associated with a worsening of a neurological event. This gentleman, this is our first long COVID patient, so to speak, that we rebrand as post-COVID-19 neurological syndrome. Alistair is absolutely right. This is the rarity. It is rare for a very sick COVID-19 patient to demonstrate these symptoms. What you normally see is what is unpredicted at the onset. Patients who had community acquired mild COVID that experience persistent, the long-term symptoms are more commoner than this. So we then went on to play with these cell markers even more. We ended up multiplying the neutrophil count and platelet count together, and then dividing that by lymphocyte count. So the rationale behind that is we all produce about few billion neutrophils on a daily basis. They die on a daily basis. We produce few billion platelets on a weekly basis. They die week or so more time later. Lymphocytes, on the other hand, they are like our hardcore secret service agents in the country. Let's say for an argument, suddenly we decided to establish a political party like Green, all those the tail group that we had who bulldozed a couple of our giant politicians. We then decided to have a conspiracy against Australian government. Let's say, for argument, that's what this discussion is about. Tomorrow morning we would have various the federal, the police agencies and other things tapping us. I hope this statement would not get us to that trouble. That's because our secret, the service agents are pretty powerful and active. Same with lymphocytes. So the lymphocytes keep a very close eye with the help of the things that Alistair mentioned as cytokines and a variety of other chemicals, to keep a close eye on what's happening to this magical body that we got with 1 in 400 trillion random chance. So we noticed that when we mark this serially, it the predict the variety of neurological events at a variety of time points, which we plotted in the second chart. So the serial systemic immune inflammatory indices at each of these time points were either related to confusion, brain fog, excessive fatigue that the patient couldn't mobilize, or extreme anxiety, almost to the extent of panic attacks, so on and so on. That was, by the way, my fastest publication, as I submitted it to one of the editors and he got fastest peer-reviewed, and it got published unedited with 2 typos in it 3 days later. We then went on to... Yes.
Sorry to interrupt. We've just got Karina who's got a hand up. Karina, I'll just unmute you. Did you have a question for Tissa?
Hi, Karina. Fire it away.
May have been a accidental hand up.
So hopefully people can hear me okay. My voice is not the great. I didn't have any voice 2 days back, but it is coming back now.
That's okay. We'll circle back at the end. Sorry to interrupt.
That's okay. So basically, I won't bore with a lot of detail. This manuscript that we revise at least 100 times before submission is probably one of the best in this area. We were arguing with the other clinician scientists why COVID pathophysiology is predicting the vascular events such as stroke as an expectation rather than exception. That was now by this time this was downloaded well over 10,000 times. The reason is this. Again, I won't bore you to this. I publish this in the Australian Family Physician Journal also as a concurrent publication. Here I am saying that everything that Alistair said about lung in alveolar pneumocytes, how it is nicely matching in brain neurovascular interface, and how with any infection for that matter, with the changes that are happening in blood-brain barrier, how it is impacting brain involvement. So the magical brain that does everything that we do today is actually at crossroad due to infections. Because I was asked to touch about headaches, I'll sort of change the tag now. So far what I tried to convince you is your brain that has 100 biological electrical wires known as neurons and 10 trillion connections that are known as synapses, which by the way is the difference between us and human. This is why while you can replace a dead goldfish to convince your children that goldfish didn't die, you couldn't do that to their sister or brother. So you couldn't replace their dad or your dog even. They quickly recognized that because of the interesting connections that those animals and their siblings and us make. So coming back. So having convinced that, now I would say what we do know about headaches and the migraine. So the Bob Shapiro is a big headache guru from US, and Patricia Pozo Roshi is the current Secretary General of International Headache Society. They went ahead and first did a systematic review going through well over 3,000 published the material since the pandemic hit us, and they went ahead selecting 48 studies for a meta-analysis. What they figured out is pooled prevalence of symptoms and signs of COVID-19, that 1 in 10 of them had a headache. Only 1 in 10 of COVID-19 acutely unwell patients reported a headache. Patients with a headache had, interestingly, more than 2 times higher chance of survival benefit, and also reasonable the reduction of length of stay. While I was interested in headaches since I was a medical student, as I myself suffer from headaches, I didn't know migraine at that time. Now I know. This is the first time that I see a literature supporting that if you get a headache, your chance of surviving this sort of a pandemic is twice as or 2 times higher. And you went home early compared to those patients who didn't have a headache. Then the Bob's group went on to do the National Health and Wellness Survey database cross-section. And here they went ahead and studied a bunch of patients with COVID-19, the with and without, migraine with and without, and number of the medics visits and vaccine status. They had the almost 70,000 total responders with a reasonably decent number of migraine patients and 58,000 who claim they had no headaches. The usual, the average, the age and male-female percentage for any headache study, as you can see, mean age, young age group, the female-male percentage among migraine and without migraine was matching well with 1 billion migraine and other 6 billion no migraine world at this point of time. Interestingly, 3.82% of migraine patients were there among vaccinated cohort compared to 2.42% without migraine in the total cohort with positive COVID-19 test reported the numbers slightly higher in without migraine. It's reasonable given the 7,000 versus 60 or close to 7,000. So it's pretty much a matched sample. So this study taught me that the people with migraine, while the headache disorders did give them a survival benefit, they seems to have had a higher incidence of COVID-19 and increased number of physical symptoms, suggesting the possibility of either they are more prone to COVID-19 or because they were suffering from a chronic brain disorder, they were more aware of symptoms and perhaps they went ahead with tests and became positive or more likely to report their symptoms to doctors. Despite that, despite more of them had COVID-19 and more of them reported their symptoms to doctors, they did use less health services and resources compared to the other groups. Some even didn't seek a medical appointment. They certainly didn't seek extra resources. The group is studying long COVID data as we speak. We don't have them to share, perhaps in another 6 to 12 months. So what do I think, having managed probably a couple of hundred COVID-19 and the neurological involvement over the years, for me, this group of patients that I do like to the rebrand as post-COVID-19 neurological syndrome, at least the long COVID cohort that comes to us with neurological symptoms such as brain fog, all those beautiful the P things that Liz talk about, they probably has what is known as post-COVID-19 neurological syndrome. This is very much similar to what I do see after stroke, a bunch of AFL players that have been seeing over the years with persistent the post-concussive symptoms, sometimes with other infections, sometimes with the more chronic migraine even. They tell me that if they didn't tell me that they had COVID-19, I could easily slot them into any one of those brackets. I think the way that our amazing brain work with rest of the other symptoms, although Alistair decided to do respiratory medicine and I decided to be the head of neurology and stroke at Western Health, and Liz decided to practice holistic medicine in primary care, we all deal with the same kind of brain, same kind of pulmonary system, same kind of cardiovascular systems, and absolutely the same endocrine and the hematological system. So when we get a threat, whether it is a head injury, stroke, or infection, all these things work in concert. I think the most neurological disorders, migraine, long COVID, the post-COVID-19 neurological, the syndrome cohort in particular, there seems to be persistent psychoneuroimmunological impact driving those things. But NHMRC allocation for these funds pathetically low. In a way it is happy, but in a way it is sad. There are way too many bright boys and girls in Australia who are competing for a very small amount of money. And every grant application that I write, I normally make up my mind, although you feel very good about the submission, that you know that you are going to miss it by 0.4 or 0.6 because someone else has done just a tad better job in a different field rather than your ambitious brain things. So the headache and neurological symptoms are the really enigmatic things, including long COVID and headache space in particular, hugely important. I think I showed you this before. While this had been cited by 28 people thus far, only small number of groups of people are performing these tasks in a number of cohorts. I think we should continue to expand this and then add some of the sophisticated complement and other cytokine things intermittently. I recall one of my PhD students who did a brilliant PhD a few years back on stroke patients with discovery proteomics. This is, you could run a bunch of proteins on admission, 3 months, 6 months, 12 months. We saw distinct behavior of some of these proteins at different time points, specifically with people with depression and anxiety. This is more or less the same, but we have not been funded to replicate that work in long COVID, just as yet we keep applying for grants. I'll probably skip this slide. This is a long new daily persistent headache after COVID-19. Those of you who have not heard of new daily persistent headache, it's a very disabling disorder. The definition is just as the name. Your patient is going to come and tell you that on 13th of February 2020, I woke up with a headache. I never had a headache. That headache never went away. That's new daily persistent headache for you as long as you're not missing something else. For the case report, I'll just share this the small snippet that I put into one of the grant applications. You can wish me luck. The red news on this grant application has not came to my inbox yet. It would hopefully in the coming weeks. This is one of my patients, psychologist by profession. These were exactly her own words. I felt totally lost after COVID-19, lost in the system. I have not been able to return to my work as a clinical psychologist even 14 months after acute illness. I had 26 physiotherapy sessions and had an antidepressants, I think 3 or 4 types, did not help me at all. Persistent fatigue and brain fog has destroyed me and my family. I had 3 normal MRI scans, and you are the 5th neurologist that I am going to see. And all 4 of your friends told me that there's absolutely nothing wrong with me. I am at a loss. She ticked all the boxes for what I like to rebrand this cohort as post-COVID-19 neurological syndrome. So why this is reasonably important from brain fun the front now? I'm sure you probably haven't heard what is known as IGAP. IGAP is the shorter version for Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders that all health ministers in Geneva, physically and virtually, including Sri Lankan Health Minister, including Australian Health Minister, agreed to act upon during next 10 years. You might think that access to neurological care, the addressing the vision of reducing the burden of headache disorders, stroke, the long COVID or post-COVID-19 neurological syndrome, or whatever the name that you like to call it, dementia, the peripheral neuropathy, multiple sclerosis, they all agreed to put a priority and act upon them within the next 10 years. You might say that we are a rich country, we got 550 neurologists, we got this right and we don't need to worry. I would remind you that most of your public hospitals, your waiting time to get a neurology appointment could vary from anything from 6 years to 9 years. Sometimes I see patients 9 years after their referral. I feel like digging a 200-kilometer hole and going down rather than seeing that patient. So we all have a long road to go. I think I won't bore you on this. You have seen those slides. We did some work with Egyptian colleagues, and we showed the world that nearly 50% had definite brain involvement from encephalopathies, inflammatory CNS syndromes, strokes, peripheral neurological syndromes, miscellaneous. Then we start advocating about long COVID, post-COVID neurological syndrome in the popular media, your journal, other journals, then other groups such as Nivyoka and others capture that also. You already saw that before. Liz already went through some of these things. I think this is tip of the iceberg. I still believe, at least among health workers, it is I know that I got a biased sample. It looks to me like 1 in 3 of healthcare workers who got COVID-19, at least during the first wave and second waves. Most of them recovered by now, but some still have lingering symptoms. I have a couple of patients 2 years down the track, still can't get back to any work. To remind you of the scene, we lost nearly half of our senior emergency medicine, the department nursing staff. I'm not saying for long COVID, for a variety of reasons. My own neurology unit that is catering for 1.2 million Victorians in Western Victoria, I had 71 the nurses in shift work. I had fabulous nurses who worked with us for 15, 16 years. I have none now in the ward. We now have to work with them to train them up to work with us as working in public hospital in complex specialties such as neurology is a contact sport. You could be the most brilliant neurologist in the world, but you got only one brain. You need your team players. So we have a long way to go to get our things back to some sort of normalcy, some years. So it's a big deal. What might give us the best money to put a stop to long COVID, at least neurological side? As I said, while different people quote 5%, 9%, 30%, 90% from what Alistair quote from those younger cohorts. It's an evolving story. I don't think we have a good idea about the impact of variants. We are all living in this complacent society. What would happen for the bankrupt countries while the COVID-19 is playing havoc? How do we deal with them? Are there long-term impacts? Are we going to see whole bunch of Parkinson's disease and dementia patients, encephalitis lethargica, type people in time to come. I hope not, but we should keep an open eye and open mind. I think the most important thing for me as a physician who represent brown skin community, who look after people from more brown communities, as we look after the people coming from 166 countries in Western health catchment, there's very little attention to these core groups, almost similar to what you see in Torres Strait, the Aboriginal and Torres Strait Islander people. And unfortunately, nations who are primary home for those folks, most of them are bankrupt now. So they are trying to find their basic food. They're not going to support medical research and other things. So there is a crying need for all of us to put our heads together, and hands together, and preserve this amazing opportunity that we had with 1 in 400 trillion chance to be born as human. What clinical data should we ask in these sort of things? This is a snapshot of what I think as useful. By no means, this is not my way or highway. These are my thoughts as I shared with you earlier on. Fatigue is a very big thing. I strongly endorse the 3P things that Liz mentioned. Some people go and write bad reviews about me, saying that I believe too much about mindfulness. Of course I do. The mind is the forerunner of everything. How I run my mind behave, how my respiratory system even behave. I can get 10 patients to Alistair if he keep me in the emergency department by choice, by manipulating how they handle their respiratory system within 1 hour. He being a clever physician, he would figure that out quickly, but he would still have to see when ED refer those patients in. So there's strong consensus from neuropsychology groups globally. We do know what works, what doesn't work. We do know what works for culturally diverse groups. Anyone who wanted to study these further, let me know and I'll get you the links, connect the dots. Headache and dizziness is a big deal. There seems to be a survival benefit, but there's a whole lot of magic that we do need to unravel. Same goes with dizziness and lightheadedness. Both of you touched upon autonomic nervous system symptoms. This is a fabulous thing, but the autonomic nervous system work is complete the can of worms. I know the world leaders in autonomic nervous groups globally, but one group doesn't do the same thing that the other group does. So it is very hard for you to come and do compare contrast thing. You can Google a thing called Compass 31. That's a nice questionnaire that is universally collect autonomic nervous system involvement, but you need to have a Mayo Clinic partner to interpret that. I can get that for you because they work with us on a couple of other projects. Sleep is a major issue, and we are part of a group called COVID-19 Global Coalition with regard to brain. We are heavily debating, including tonight with the WHO symposium over 2 hours that I'm supposed to be sitting till 1 a.m. We would hopefully have some sort of a consensus on preliminary data, and I'm very happy to share those things with the PHN and the primary healthcare networks. There's a plethora of objective tests, the functional vision test. I don't have time to share with you. We do have technology built in Melbourne now. You could have a basic retinal camera that they take a picture while you are sitting automatically in the rooms. You can get your practice nurse to do that. And we have developed artificial intelligent kits that is going to tell you your patient's brain age, vascular age, and this. I am working very closely with this group, and we are pretty determined that we would have something out there for a very low cost that you can keep in your practice that could work with your optometry colleagues to make your life and your patient's life much easier. I still believe that very cheap $5 white cell count has a lot more to tell you. We just need to do a bit more science to marry that, but we will do that. I promise you, if I stay alive for another 5 years, we will fix that mess for you, with you. And if you wanted to get involved more, we are launching World Brain Day on 22nd of July. I am the chair of this event. If you wanted to have on-site thing, I have invited Monique Ryan. Not that I'm the Teal fan or anything like that. I was more of a fan of Josh Frydenberg, to tell you the truth. But Monique is a colleague neurologist and a friend. and she's the first neurologist who is going to be in Canberra. So she will share her thoughts on brain health, and we would have a couple of star AFL players and a few other speakers. We would try and give you some sort of a nice snack and brain healthy drinks also. That's at Melbourne Brain Centre, 4:30 to 6:30. Haven't opened up the registration yet. It's free. Please come for a face-to-face event. We will practice all the COVID-19 safety things. I will be coming to your PHN also later on. That's one activity where you can get involved and promote brain health. If you don't feel like coming, just Google World Brain Day, visit our website, download the toolkit, use whatever the social media platforms that you have. That's a very depressing number that we have. Basically 1 in 3 of us are having a brain disorder. Among this panel, one of us, including me, could well be having Parkinson's disease, could well be having Alzheimer's dementia, could well be having frontotemporal dementia, could well be having early stages of multiple sclerosis. I already told you that I'm already suffering from migraine, and we need to put a stop to that. And the only way that we do that is raising awareness. Moreover, on 28th and 29th of July, we have put together 58 complete free access to superb headache education program targeted at neurologists, but I have listened to a couple of talks as I'm recording them on the go on a daily basis for some time now. They are pretty easy to follow, and we will have speakers answer your question. You will have 1-year website access if you register, and you would have lifetime access with a mobile phone application to access the talks later on. That's on 28th and 29th. I would probably open up 10 GPs close to 566 Bell Street, Pascoe South, to be on site on some of these events as we will be webcasting them from that place. Lastly, over the last 2 years, we have developed a CPD producing educational course on migraine, as there are 8.4 million Australians suffering from migraine as we speak. You are not going to get me to see these patients for another 300 years. If I were to see them, I could only see 4 or 5 patients per afternoon. These patients are hardcore. When they come to us, they take 1 hour from us to take a history and examination and formulate a plan. Therefore, the only way that we can put an end to this misery is getting some of you on board and finding a way to working together. I'm strongly advocating to get Australian GPs to be able to prescribe some of the new migraine medications also. That's an uphill battle, as you could guess, but we'll give it a go. We got this fabulous chance of being 1 in 400 trillion chance rather than 2 other cells. Life decided to bring us, so we should make matters useful for the community. Again, on 9th of August, we will do a recording of these events as we set off Bangladesh Headache Society virtually from here. We would open this up for 10 local GPs on site, 522 Bell Street, Pascoe South. We are not rich, but we would be able to give some sort of a reasonably healthy meal and organize your stay comfortable for the evening that you are there if you do want to take part in it. With that, I will stop, and I'm happy to take questions on long COVID, headache, pretty much anything to do with brain.
Thank you so much, Tissa, for that really interesting presentation. We do have a couple of questions that I'll just put to the panel. So the first one is just a general question. Does death tend to occur mainly in the acute COVID, or have they occurred in long COVID patients? Not sure who wants to take that one.
Yeah, I kind of ignored that one in the Q&A. I think it's really hard to answer that. Certainly the majority of the deaths that are reported every day are those that occur in acute COVID. I think it's much harder to count those in the long COVID space, and certainly many of those diseases that we've talked about tonight, venous thromboembolic disease, myocardial infarction, stroke, are all much harder to link in terms of reporting. But long COVID, I guess, in the context of not having another measurable disease, I don't think there have been, there's not case series, and there's not significant reports of people dying in that context.
Right.
My short answer to that question is I agree with the Alistair. We don't know the exact answer to that question. Our experience and our discussions with other experts is while it doesn't seem to have a high mortality on published figures, it certainly kill human joy 100%. If I put 300 plus long COVID patients that I had seen in my hands, I can tell you that they were the most unhappiest patients, and you spend twice or thrice as more time with them to instill hope in their mind and the promote recovery pathways in whatever the way that we can. Important to note that the way that we should use multidisciplinary teams while we are still learning how we use them, it's never going to be one size fits all approach. You have to decide which patient would benefit from exercise physiology, which patient would benefit from a good clinical psychologist, which patient would have the most to gain by seeing an occupational therapist. It is hard to decide by ourselves. This is what takes time. So you need to get into their head and try your best to match what would help these patients best. I would also like to add one thing to the death. I wouldn't name, I remember when I was lobbying with one of the federal health ministers, quickly a word came out, this migraine doesn't kill people. I immediately responded to him that it doesn't kill people, and I quote his first name, but it killed the human joy and neurologist joy completely, those of us who had to put up with these patients in long consults. That is true. Same is true for this. Then when I came back from this meeting, I did a study, then I converted it to a paper. We reported for the first time in the world, you can Google and search this paper, we told the world that migraine patients are 3 times at higher risk of taking their own life that nobody talked about before. So that's a death. So I suspect in another 2 years' time, we would come to know the reality of death in long COVID. I'm pretty sure that it killed some people. It should increase suicide on a number of patients that we wouldn't have data at this point of time. We would in time to come. But if you don't believe on those things, I'm sure the rest of the other panelists agree that it certainly bring enormous amount of misery to the patients, and it bring enormous misery to the physicians also. Sometimes I ask other neurologists to see a patient. I tell them that I know that you haven't got anything more than what I have got, but I do want different pair of eyes and different pair of hands to put on this patient. It would help me to help this patient so that we can somehow instill hope in these patients. I think the critically important thing is creating hope. And I'm of the firm belief that all these patients should get better. We just need to learn the way to modify that psycho-neuroimmunological pathways, by the way, extremely complex to manipulate, but there has to be a way. We just need to figure that out with the resources that we have, as nobody's going to give us any more resources than what we have. As we continue to get old and weaker and frail, as we add years to our life also.
Indeed, Tessa, thank you. So on that, I guess prevention is better than trying to fix at the end. So a question for Elizabeth, I think. Apart from vaccination and strategies to avoid infection, are there any other ways to prevent long COVID?
I think the short answer is not that we're aware of. We're not sure yet about what role antivirals will have and other early treatments will have in reducing rates of long COVID. But of course, the prescribing of that is quite strictly controlled, and there is no consideration into reducing with long COVID as part of those prescribing matrices. So I would say we don't have any other evidence-based ways to prevent long COVID at this point. Alistair, would you agree?
Yeah, absolutely. I think, you know, everyone's looking, but I don't think we have anything at the moment.
Great, thank you.
Contrary to that, I have a slightly different view though. Without telling too many detail, I became very sick with a significantly life-threatening illness about 6 years ago, and I ended up in a vascular surgery ward in Royal Melbourne Hospital, as my specialist couldn't get me to the hospital that he was wanting to get me into. To cut a long story short, I was told that I was potentially going to die in 2 months' time unless I had this, and that, and I opted not to go through that path. I didn't die, of course, and subsequently my diagnosis changed. Those 2 miserable months, one thing that I work is, the one thing that worked very well for me is, during my hospital stay at Royal Melbourne Hospital, not that other patients should follow, I became a very difficult patient. I told my nurses with my inflammatory markers very high that I would just go down to the hospital cafe area and just totter around. I promised them that I would not walk away from the hospital. And then slowly I walked into the Melbourne University grounds, and I spent more time under big trees and watching birds and watching all those young students giggling and doing other things, completely living at the present moment. And then when I was discharged, I again became a difficult patient, and I spent in rainforest in the northern Queensland with my 10-year-old son at that time, watching very rare birds and so on. I think there is not published evidence, but a lot of anecdotal evidence in long COVID out there, specifically with brain fog, that positive thinking, the supporting, the stopping rumination, the activating those pathways, or the 3P things that Liz mentioned about. I think your college has a nice document to deal with fatigue. All those things help patients to recover faster. Medication-wise, again, there are no sort of a randomized double-blind control to support this. Many of my patients self-treated them with the slightly higher doses of melatonin. Some take turmeric tablets. So I think positive attitude and not ruminating on things and not feeding into these negative loops, and then using allied health inputs strategically, knowing that which aspects help, certainly help you to not to get long COVID, as well as to come out of that faster. I think we helped a large number of patients. There's a small number of patients that we still, they split our hair to get back. I still tell them that you don't have holes in the brain, and I want you to get back to normal, and I want to see that you're at full-time work eventually. That's the notion that I'm playing even now.
Great, thanks, Tissa. We did have one question regarding medication. So is anyone doing a trial of low-dose naltrexone for long COVID, and are there any drug trials for long COVID patients to participate in Australia?
So there's not any trials of naltrexone in Australia that I'm aware of. There are a couple registered on clinicaltrials.gov, but they're not recruiting at present. The only drug trial that I'm aware of in Australia is being run out of RPA, I want to say, somewhere in Sydney, looking at colchicine. But interestingly, and I think this is common in many of the long COVID trials. When we're talking about long COVID, it's recruiting people in their acute illness and starting the drug then, or starting it in the first few weeks post-acute illness. And so I don't think, because the long COVID space, that sort of 12 weeks to 2 years is so diverse and difficult to define, it's really hard to run a trial in that space, and the people just aren't doing it. Most of the trials, the vast majority of the trials, are still looking at epidemiology and risks perhaps for developing long COVID. There's very little outside the rehab space, and I think, you know, our rehab colleagues have really stepped up to the plate on this. That there is lots of data in that space, but very little in the drug treatment space.
So we do have another question, which is there any psychosocial support groups in the long COVID clinics at the hospitals currently?
I can only speak for RMH. I'm not sure this. I'm not sure they're doing group therapy or group sessions. There are certainly both psychologists and neuropsychologists and a psychiatrist within the service at RMH.
Great. And we've just had a couple of questions. Oh, sorry.
I was going to say, many patients with long COVID are using social media to link up with other people with reported long COVID, which has got, of course, strengths and weaknesses, but that sense of being validated is really important, and telling people that their condition is recognised and real, I think is really important.
Thanks. This is a question from the chat box. Where can we find more information about revalidating / risk assessment for PE?
Yeah, so look, I think my slides will be available at some stage, but it's the YEARS algorithm, literally just YEARS. It's on all the med calculator apps, but it's pretty simple. So there are, you know, loads of publications on the YEARS algorithm, but yeah, it's on MedCalc and all those sorts of things in terms of that risk assessment.
Thanks, Alistair. So we've got one of the participants who's shared their sort of personal story in the chat, but one of the questions relating to that is sort of has long COVID, sorry, I'm not going to say that right, arthritis, and takes methotrexate as well as some prednisolone, headaches, incapacitating. What is the best advice for someone like this person who is taking immunosuppressive medication in terms of long COVID? Sorry, I haven't done a great job of summarising what was very detailed chat, so thank you for popping that in there.
I'll probably start. I think the first of all, our empathies for this particular person. I think it is very important not to lose hope, as I mentioned. Be hopeful. Don't give up. The fact that you are here, even with psoriatic arthritis and long COVID, is a miracle, as I pointed out before. 1 in 400 trillion. So be happy. And then to deal with the long COVID symptoms, every little thing that you do helps. Do things that generate a whole lot of happy chemicals when you can. Even if you walk around the house, walk inside the house, every time when you hug your dog or cat or pillow or kids or your partner, you generate happy chemicals in the brain. That helps. Where possible, do some exercise. There is a research paper, not in long COVID, but in chronic migraine from America, saying that those people who walk for 40 minutes per day for 5 days per week for 6 months had same level of headache day reduction compared to topiramate 200 milligram daily. I have a few thousand headache patients, and only 2 patients I managed to put topiramate 200 milligram, because topiramate 100 milligram make you look silly, you lose your voice, you get confused, you get tingling, and they email you and ring you asking you to remove that medication. So walk as much as you can. There's no sort of established dose of exercise as such. If you feel like miserable, but if you're in the mood, just put on the best music that you like and sit on a chair and wiggle your toes, wiggle your fingers. Every little thing helps. Eat a healthy diet, olive oil, fruits, vegetables, nuts, beans, whole grain. All those things are proven to be brain healthy. Although you feel like drinking wine and beer and other things, these are not the times to do that because they are toxic to your brain. So I would avoid anything that is toxic to the brain. Sleep well as best as you can, when you can. And as much as possible, participate in social activities. There are a whole lot of peer support groups from overseas, from UK. There's a very decent peer support group. we are trying to create such a group, and applied for funding again with NHMRC. If we get it, we will create something here also. And do whatever the thing that cognitively exercise you. If you are not into bird watching, get hold of a little bird field guide and see whether you can recognize a couple of birds that are coming to the garden. Look at their beak, look at their feet, look 3 small birds, how do they be different from each other's. So basically, the summary is do all brain healthy things when you can, and don't punish yourself when you can't. You can manipulate your immune system significantly well, positively. I certainly did 5 years ago. Otherwise, I wouldn't be here today.
Thanks, Tissa. This is a question I think that comes up most times we have a COVID session, but are we meant to be prescribing everyone budesonide or similar, or only if they have asthma/COPD? I'll give that one to you, Al.
Yeah, thanks. So look, I think in the acute setting, you know, the trials that were done, the STOIC trial and the Principal trial, looked at people who weren't on steroids and, you know, didn't have a reason to have it otherwise, but were at risk of disease, certainly in the Principal, risk of severe disease. And so certainly in the acute setting, budesonide is useful to reduce the chance of progression to severe disease. In the post-acute setting, you know, we don't have trials, and I guess it's really analogous to other post-viral cough and post-viral breathlessness. For those people who have a cough that sounds bronchitic, that's kind of that tight, wheezy cough, you know, usually dry or minimally productive, it may be useful in those people. You know, I don't think we can say that everyone should get it, but I think there are some people who will benefit from it. Similarly, you know, reflux, if people have untreated reflux or reflux symptoms despite PPIs, you know, treating that can also be useful in that context. So look, I don't think it's for everyone, but I think for a group of people, it can be very useful.
Great. Thanks, Alistair. So it looks like we've got through most of the questions. I'm just checking the Q&A, just going to give people a minute if they were typing a final question, or if you want to put your hand up, we can unmute you, please do. But if there's nothing else, we have put a link to the evaluation in the chat, and really appreciate if people could take the time to fill that out. That's really useful. We do look at that feedback in terms of future sessions and how we can improve things. I do just want to thank everyone again on the panel for their time tonight. So Alistair, thank you to you, to Tissa and to Elizabeth. It's been great to have you involved, and I think these multidisciplinary sessions where we hear a little bit of tidbits from everyone is fabulous. And thank you to everyone who joined us on the line, particularly on a cold Wednesday night. And we might take some of Tissa's advice and stay positive about the great work that you're all doing out there. So thank you so much. I'm just checking. I think they're just thank you things. So thank you all so much for joining us, and thanks very much to Sadia and Amanda in the back end as well. Enjoy your evening.
Thank you very much, and have a lovely night, everyone.
Thank you.
Thank you. Good night. Bye-bye.
Bye.